Hello, good afternoon, everybody.
Hello.
We are just going to wait for one more minute just to see if there's any more people that are going to join us. Hopefully you're here for the Mental Capacity Act. So I just wanted to scare you then, Lisa, into what training you were doing.
Yeah.
Mental Capacity Act
Throwing me a
training.
curveball there. It's nice to see some names that I know. That's nice.
You brought your crew with you, did you?
Yeah. Recruited some faithfuls, yeah.
Good. Well, I know that Lisa has got a jam-packed session, so we will get started. So good afternoon, everybody, and welcome to the webinar on the Mental Capacity Act. First of all, can I ask that everybody turns their microphone off and keep your cameras off, please? Thank you very much. So just to let you all know, thank you very much for joining. We have got Lisa joining us from the South Central Ambulance Service to talk to us about Mental Capacity Act. I am going to put up a poll at the beginning of the session, which I'm going to ask people to complete, just about your confidence levels in terms of mental capacity. And then before we finish the session this afternoon, I'm going to ask you again about your confidence level. So just in terms of the session, what do you think it's given you in terms of your knowledge and confidence of Mental Capacity Act? The presentation and the webinar itself will be available on the Safeguarding Adults website, more than likely towards the end of the week or the beginning of next week. By the time we've got through the videos, we will be able to put them up on our website. So any information that you need, I would suggest having a look on the website and seeing if any of the information is there. Also, please do get hold of myself or Lisa. I'm sure Lisa won't mind if you've got any specific questions that you didn't feel like you could ask during the session. We have said that if you want to ask questions, you can ask questions during the presentation itself. If you put your questions in the chat, then I will let Lisa know and we will be able to get your questions answered. I am going to put the first poll in and then I'm going to hand over to Lisa. So bear with me. In fact, I will hand over to Lisa and then I'll put the poll up if that's okay. Lisa.
Absolutely, thank you. Let me just put my slides up. So just a little bit of an introduction, just to say I only work from one screen, so I am at the mercy of you popping your hands up and letting me know if you've got a question. If you pop it in the chat, I won't be able to see it, but Marcia's very, very kindly said that she'll keep an eye on the chat for me. My preference would be that we have questions as we go through, just because then those answers are fresh in my mind. But if there is something you want to stay on the end of the call for to talk to me about in particular, I'm absolutely fine with that. And I've also dropped my email address into the chat so that if there is something else that I can help you with, I absolutely will. So can you all see my slides on the screen? A little thumbs up. Let me shout out. Yeah, brilliant. So can you do your poll thing whilst I've got my slides up, Marcia? Does yours? Lots of thumbs up there. Brilliant. I can see everyone's fantastic at using those functions in Teams. We've got a hand up. Is that a question already? Oh, you're on mute, Marcia.
So basically, it's how confident you feel about the subject matter, and that's prior to obviously having this session. So if you could just respond whether you're extremely confident or extremely not confident, or anywhere in between.
Do you want to let me know when that's all, when you're happy with that, and tell me when you want me to start, Marcia?
Yes, I will do.
Brill.
Thank you. Yes, the session is going to be recorded, and when it's complete, it will be up on our Safeguarding Adults website. Okay. Thank you, Lisa. Over to you.
Lovely. Thank you so much. So welcome, everybody. Thank you for coming. It's lovely to see so many of you here on this session today for our Adult Safeguarding Week. Just so that, for those of you that don't know me, I'm Lisa Pearson. I'm Safeguarding Specialist Family Practitioner here at South Central Ambulance Station, and I take the lead for mental capacity and DOLS across the Trust. I'm a social worker by background, so I was a frontline social worker for about 25 years. Worked across pretty much every single care domain, so sort of mental health, physical disabilities, learning disabilities, transition with children, so got a real kind of breadth and depth of knowledge. I'm also a qualified best interest assessor, and I'll talk about the role of a BIA a little bit later on in my slides. So like I say, any questions as we go along, please do shout. No silly questions, just put your hands up and let me know. So we're going to begin with talking about age and why is age really important when we're talking about mental capacity. So we align our laws with England and Wales when we're talking about mental capacity, and a lot of our laws are aligned with England and Wales, but the government decided to set mental capacity at 16. So that's really important that you hold on to that, because a lot of our laws, as we know, are 18. But when we're working with our patient, if they've turned 16 the day before, they're now afforded the Mental Capacity Act, and we need to ensure that we give them this legal framework around them. Just be really mindful that when people, when you're working with your I'm going to call them patients because I work in the ambulance service now, and my brain has switched over from saying service user to patient, that when you're working with your patient, you might get those parents or guardians who say, oh, actually, no, hang on, my child's under 18. I am their decision maker. You know, I want them to, or I don't want this to happen. And we're very respectful about that, but we have to point out to them that no, mental capacity is 16. We're not going to completely ignore them or push them out of the fold. We are going to bring them into that conversation we're going to have, but it doesn't buy them that right to make the decisions for their child. And equally, just be really, really mindful, next of kin doesn't get you that either. So next of kin purely is you have been appointed the person to be told when that patient dies, that's you're going to be informed of that patient's death first. Okay, so lots of people from experience when I've been working in the community in hospitals will say, but I'm next of kin, so I want this to happen, or I don't want that to happen. So just be really mindful that's not the case. And we've actually got, in a few slides time, I'll talk about those people that do hold that power to be able to act as that decision maker, having that patient's voice. Okay, so just bear in mind, mental capacity is set from 16 years of age. So we often talk about consent in the health service. You know, consent is a really important way to start working with our patient. And we know consent is our gold standard, isn't it? That's where we should be. We should be having these open and honest conversations. But we know there are times when we have to override consent. And then one of the most simplest ways of doing that is by recording a mental capacity assessment. So again, in a few slides, we'll talk about how we can use mental capacity assessment if we're thinking around consent with our patient. And just on a footnote, obviously we can override consent when we're worried about control and coercion. So if we're seeing any domestic abuse, or if we're really concerned about public interest. And that's a really important one to hold on to, because that can be really helpful for those patients that we work with that are really risky in the community. But actually, if they do have the capacity for those risky decisions, actually, if it pulls across into a public interest concern, actually we can override that consent there. So that's a really helpful one to hold on to. So I'm going to move on to talking about the 5 principles of the Mental Capacity Act, and this is the absolute sort of bottom foundation rock of the Mental Capacity Act. Just to be really clear, when the government brought the MCA in, it's 20 years old now, I can't believe it. Like, I remember when it was first brought into practice and we were all taught, you know, mental capacity, how to assess capacity when I was a frontline social worker. This is an empowering piece of law. Yeah, the government brought this in to stop professionals from going in and doing things to people, for people. Yeah, we stop and we have this really good conversation with our person and think about this in an empowering way. So this is how I was taught Mental Capacity Act 20 years ago, and I know our crews in the ambulance service really like to remember this as the way of remembering your 5 principles. So we do presumed capacity, so thumbs up. So we have this, we make a presumption of capacity, because what the law doesn't want us to do is think, well, I'm going to see my patient in a dementia care home, therefore they must lack capacity because they're in a dementia care home. That's absolutely not what we do. We think that's really helpful information, really good for me to know that I'm going to a dementia care home. That's where my patient lives. And it's when I start having that conversation with them, that's when, if I start to get those doubts from that conversation, that I'm concerned about what they're saying to me, or, you know, information they're sharing, I think, actually, no, I have got a doubt now. I'm going to come on to use the Mental Capacity Act. So principle 2, I like to think about this as like a bit of a wagging finger. And what am I going to wag my finger at you guys for, to say, what support do you need to give your patient so they can make their decision? So this is a really important principle. So we need to think about, you know, does the person wear glasses or hearing aids? Have they got their hearing aids in? Are they in the right ears? Are their batteries switched on? You know, really think about your environment. Actually, you know, if you're in a room and there's light shining on your face, can the person you're trying to talk to actually see your face? Yeah, can they see your words being formed? Think about the noise. I find noise a real distraction, you know. So if I'm there assessing someone's capacity and the TV or the radio is blaring in the background, I really struggle to concentrate on what the patient is saying to me. So again, it's just really fair that we say, can I just turn that telly off, or can we turn that radio down just whilst I talk to you? So really important that you set a good scene for this conversation that you want to have. Equally, if your person uses sort of Makaton or sign language to communicate, we don't just think about communication being the spoken word. You know, if we think about people who are using light-writer computers, might be using signs and symbols, we need to go out of our way to make sure we can communicate with that person. And also, if English isn't their first language, we need to be getting onto our language lines, our ways and means to be able to communicate with this person. And again, I would be saying, if you're doing a mental capacity assessment and it's around a very, very important decision, because we know it's decision and time specific. So we're going from those really low level decisions about, you know, does your patient want to wear a jumper or a cardigan? What's their preference? All the way up to how they might feel about having a major surgery. Yeah, you might want to use, you know, some very simple ways to communicate with your patient over those low level decisions, but those much higher levels of decisions, you absolutely would want a correct translator there. So don't put yourself in that position, because you need to make sure that the patient has actually fully understood the decision, and that comes under support. So principle 3 is unwise decisions. So this was brought in as a check and balance to professionals, to stop professionals from using their power to coerce our patient into doing what we want them to do. So we know that's really, really easy, isn't it? By saying, oh, well, I think you should, or, you know, what about if you just come in for those tests, or, you know, it won't be long. We do, don't we? We coerce people along into doing what we want them to do. And the right to make unwise decisions, that's what the government wanted to bring us down. What it wants us to think about is actually, who lives a perfect life? None of us live a perfect life, and we don't expect the people that we're working with to either. Yeah, so if they're explaining to you, actually, no, you know, that's really not for me. I don't want to be going into ED, you know, I don't want to be going into that day centre, and they can explain to you the reasons why, and that makes sense, and we understand, and there is somewhere else that we can make this fit, make this work. We need to then think about unwise decisions. What unwise decisions doesn't allow us to do is go off and make the most craziest decisions in life. Okay, so, you know, I couldn't go and rob a bank this afternoon and say, oh, well, I was making an unwise decision. Yeah, that's not what the law's wanting us, saying that we can do. The guidance is, it brings check and balance to professionals to not coerce our patients into doing something we want them to do. So we say the first 3 are about me, the second 2 are for me. And that's because we've done everything we can over here to try and empower our patient. But what we're falling into now is actually we're going to have to start making some decisions with our patient's loved one. So we use this finger because it traditionally represents our wedding ring finger. So we think, who knows and loves me? So where I said at the beginning that those next of kins and parents and guardians don't have that power to make the decision, this is where we're going to be bringing them into the conversation. So, who knows and loves our patient? Is it their neighbour? Is it the neighbour that's popping in every day? Is it the day centre? Is it the carers that are coming to visit them? Is it family? Who is it? Who do we need to have other conversations with about the person because they can't make that decision? So what we don't do is, these bigger decisions in life, we don't just make them on our own shoulders. We don't carry all of that weight. We share it as a best interest conversation. And then least restrictive is your little finger, and that's because the law wants us to be least restrictive in people's lives. So if we think about our Article 8 rights, your right to private and family life that we have, we can't just go in, again, trampling all over people and their lives and their families to get what we want to get done. It may well be that you start off at your least restrictive option, but you can't actually achieve that, whether that be time, resources, just the environment, whatever that challenge is, and you end up being the most restrictive. That's okay, but you just need to show that you have worked your way up. Okay, so there's your 5 principles of the Mental Capacity Act. So hopefully after today's session, you'll be able to think, 5 principles of the mental capacity, and try and remember it in that way. Thumbs up, and we'll wag my finger. We're going to say, got the right to make an unwise decision, who knows and loves me, and what is least restrictive. Okay. Let's carry on. So this is the 2-stage test that you complete when you're actually completing your Mental Capacity Act assessment. And I hate the fact that it's called a test, because I just think this is a really good conversation with somebody. And I know when I was a social worker frontline, I would just have this conversation with the person. Yeah, so we call it a test, but think about it as that, allowing that conversation to flow. So we think about our decision. So let's think, we're talking about a consent to, let's say, a safeguarding referral. What we need to understand is, can the person understand and or retain and or weigh and or communicate the decision? So notice I've said and or in between each of those 4. That is because you only need to have one to have a lack of capacity. Okay, and there's a bit of a myth out there, I'm not sure why or where it's come from, but lots of people believe that you have to have all 4 to lack capacity, and that's not true. It's just one. Yes, absolutely, you could have a mix. You may be working with your patient and doing your capacity assessment around the consent to share a safeguarding referral. They can't understand or retain the information they're giving you. That's fine. Yeah, but as long as you've got one, you can then go on to use part 2. And part 2 is there an impairment or disturbance in the functioning of the person's mind or brain? So they're not words that we use every day, are they? But what the law is asking for us there is to say, well, why? Why can't the person understand or retain? So we don't have to go off and look for a permanent diagnosis. So we've got a really lovely broad range here. So we could say the person can't understand and retain the information around the consent to do the referral because they've got a learning disability, an autism, an acquired brain injury, a dementia. It could be a UTI. It could be that they've been drinking alcohol and they're really intoxicated. It could be that they've misusing substances. So you can see it's a whole range of reasons. We're not just looking for those named diagnoses. It's really far and wide as to why your person can't understand and or retain and or weigh and or communicate. And then what the law asks you to do now is be 51% sure in your balance of probabilities. So it's really low, 51% sure. Yeah, so you're not being asked to be 99% sure. And that's really, really key, because we know assessing capacity is decision and time specific. We're saying in that moment, when I assessed the capacity, I was 51% sure. So let's say your colleague then comes along and assesses capacity for the same decision 2 hours later. they come out with the decision that the person has got capacity. That's absolutely fine. That's not a problem. That doesn't mean you were wrong and they were right, or vice versa. What it means is in that moment when you were assessing their capacity around that decision, we were saying we were 51% sure they lacked capacity because, yeah. So there's no kind of, when I hear people say, oh, well, I assessed their capacity 6 months ago and they lacked capacity. And I think, well, that was 6 months ago. It is decision and time specific, and we should be reassessing capacity if we need to be doing so. And especially when we're talking about those much larger decisions, like I'm saying, those decisions around, does your patient prefer tea or coffee? That probably is a Mental Capacity Act assessment that can stay on that file, probably a good few years. But anything else, if we're thinking about treatments, we're thinking about involving ourselves in people's lives, or taking any action, then actually we should be reassessing that capacity. Okay, so just remember, it's that 51% sure. Are there any questions, or is everybody okay? All good?
There aren't no questions in the chat.
Well, I hope that means that everybody is A-okay and not bamboozled.
That's great, thank you.
Brilliant. So then when we got to this outcome, we've done our 2-stage test. We know the person lacks capacity. We know why. We've done that best, that discussion part. We now come back to thinking about actually that best interest decision. And I think about this as being really person-centered, really key. So it's the law tells us we must still consider what was in the person's wishes and feelings, beliefs and values. And that's absolutely key. So again, what we don't have is the ability to just go off and do what we want to do. Even if the person was saying to us, please, no, that was always too far for me. And the family is saying, no, admission to that hospital, just, we've had an awful experience there. It was really triggering, or they find that environment really challenging. We need to take all of that information into account. Okay. So this is probably a really important one for you guys, is consider whether or when the person may regain capacity to make the decision. So what you need to be thinking here is actually, again, remember this is an empowering piece of law. When I'm sat there with my patient, if I am, in that care home, I'm in that hospital, is the patient at their absolute best? Have I caught them in a good moment, or have they only just woken up? They haven't had their medication, they haven't sat up and had a sip of water. That wouldn't be fair to be assessing their capacity then. Really need to think about giving them the best opportunity to be involved in this assessment. So you have that within your gift when you're working in a community setting or in a residential or a hospital setting, because you can come back and see the patient. For the guys on the call, people on the call that work for an ambulance service or an emergency service, this is a real challenging one for us, because we know we're very, very limited in the time that we have. And often that's not within our gift to think, actually, is the person going to regain the capacity to make the decision? We're having to make a decision there and then. But just bear in mind, actually, it is something going to change this situation. Should I hold back and wait? Is that fair and appropriate to do? And then just for noting, if you come across your patient and they're unbefriended, or they've got no family, no loved ones around them, nobody to have their voice, they're entitled to what's called an independent mental capacity advocate, and that's known as an IMCA. Okay, and what can be really helpful is if you identify that somebody needs that IMCA, if you can write that on your referral, share that information with the social care team, they can get that referral done much quicker, rather than waiting for the person to be allocated, then have their care needs assessment, then do the capacity assessments, etc., etc. It can just really speed things up for people, because it's absolutely key that we have that person's voice. Yeah, again, remember, this is an empowering piece of law. So isn't very well known, Section 5 acts in connection with care and treatment, but the Mental Capacity Act is a bit unusual in that it provides a protection to the person who is using that piece of law and the person who is receiving that treatment or care. So what Section 5 tells us is, when you are working and using the Mental Capacity Act, you have this protection from liability. So you wear this cloak of immunity that protects you from any legal challenge. as long as you have use the 5 principles of the Mental Capacity Act that we talked about and the 2-stage test. And you can see these words and this language, it remains the same, doesn't it? That actually we know that that treatment or care is needed for that person who lacks capacity. We've worked in the person's best interest. It's a reasonable action that someone with capacity would have likely to have consented to that, and it's least restrictive. Okay, so this is where you get your cloak of immunity. As long as you act within the law, within the code of practice and the Mental Capacity Act, and you're thinking about best interest, likely to consent, and it is least restricted in the person's life, you get that protection. So really, really helpful. There's not many other laws out there that provide that protection to the patient and to the person enacting that. So Section 6, use of force and restraint. So this is often a challenging conversation I have, and I always think, you know, that comes with a bit of a warning of when we say the word restraint, that does not mean pain restraint. Okay, so we know the only people that are trained in pain restraint are your security guards, your police officers, those types of services, and again should only actually, you know, only used when necessary and proportionate and around a risk of harm. But actually, when we think about when we use the words force and restraint, we're very much thinking about those safer holding techniques, keeping somebody safe, you know, whether that's, you know, using a blanket over somebody's lap or placing your hand on top of someone else's hand because they're pinching or scratching. That would be your level of restraint. Okay, so we're talking that lower level. We're not talking about pain restraint in any way. And what I always say to our crews is if you're going to use a level of restraint, you absolutely only do it when it's necessary to prevent that harm to themselves or others. Has to be in their best interest, has to be the least restrictive option. So when we say least restrictive, if you're in that point where you're needing to use force or restraint with your patient, you would use it for the minimal amount of time. If the person then settled and calmed, you would obviously take your hands off that person. If they then became distressed again, and again that risk of harm to themselves or others is increasing, you would go back to using that safer holding technique. But again, only use those safer holding techniques or levels of restraint to what you've been taught. Okay, so don't, you know, absolutely don't start putting people in the prone position or anything like that. We know that Section 6 does not allow us to do that. So my advice always is, if you feel that this situation is escalating and my patient is becoming really, really distressed, and actually this is going to cause them, me or others harm, and we know that it's going above and over what you're taught in, that's when we do need to ask for the police to come and help and support us. Okay, because they are the people who are trained in how to effectively manage a patient safely, but also keep them safe and everybody else. Okay, so I always think it's a bit like a weighted scale, and if you feel that you're tipping over that weighted scale, absolutely step away from that situation if it's safe to do so. You know, if that patient is safe and you're not going to come to harm, you back away and you retreat, you keep yourself safe. And that's when we need the support from our police colleagues when we're talking about Section 6. Okay, so I'm going to come on now to talk about lasting powers of attorney. So this was brought in with the Mental Capacity Act, and a couple of really key questions you need to ask when you come across families who are saying that they've got lasting power of attorney. So there's 2 different types: there's health and welfare and property and finance. And the majority of them out there that are registered with the Office of Public Guardian, who I will refer to as the OPG, are for property and finance. Okay, so not that many of us have thought about what's going to happen if we have a lack of capacity, who holds that decision card, who's got your voice. If you don't have health and welfare LPA, nobody has your voice. And what would actually happen in that situation is we would all come around the table as professionals and make a best interest decision about what is to happen with your health and welfare. And we had a really, really interesting case. I'll drop the link in with the pack. around a policeman who he sadly experienced a horrific car crash on the way home after work, and he was on intensive care, and the hospital wanted to carry on tube feeding him, but his wife felt really strongly that wasn't what he'd want. She knew that that wasn't what he would have wanted to continue, and it ended up in courts, and the courts essentially had to make a decision around whether that tube feeding would continue or not. And that went that way because she didn't have a lasting power of attorney for health and welfare. So you can see that the power that buys you. You are the person's voice. You still absolutely, if you're nominated as health and welfare LPA, you absolutely still have to work within the person's best interest. You can't just go off and start making crazy decisions that the person would never have wanted. So you have to act within that best interest process again. Really important that you see this document when somebody says that they have it. And there's two ways to see that it's a genuine document from the OPG. It will have an old-fashioned bank stamp on the top of the page. And as you can see on my graph, the circle in red, at the bottom, there's what we call these tracking dots, and on each page it will have these tracking dots, and that shows you that that is a genuine document that has been registered with the Office of Public Guardian. I have seen far too many fraud documents, or documents where people have written their lasting power of attorney for health and welfare with the best of intentions, but never sent it off to the Office of Public Guardian to be ratified. And if it hasn't been sent off and it doesn't have those tracking dots, or it doesn't have the stamp, it's nil and void. Okay, so the document must go off and be registered. Yes, go.
Can you contact the OPG for verification of LPA, and can you view them online as well, please?
Good question. So again, it's really helpful for you guys out working in hospital care home settings or working with people in the community. You can do what's called is an OPG 100 search, and you just go onto the website, you just go onto that search page, and it will come up and it will ask you some very basic information around what is the name of the person you're searching for, what your name is, why you're asking. And normally it's about a 5-day turnaround. The OPG will come back to you and email you exactly who holds LPA for that person, what type they hold, and what ability on decision makings they have. Because when you write your LPA, you can say, I could nominate 3 people and give them all the joint same responsibility. Or I could nominate 3 people and say, well, those 2 people have got a higher weighting of decision making than this 3rd person. So it's really important that you understand who has the decision making power and what a proportion of power have they given each of those people. Okay. Just for information, to do a lasting power of attorney is really, really simple. I went on a lecture a few months ago with a professor, and he said to me, having a lasting power of attorney is not something we do in our advancing years. This is something we should do on our 18th birthday, because it shouldn't just be something we think about, oh, we need LPA and health and welfare when we're older. Absolutely not. We could all lose capacity at any point in our life. And if we haven't appointed someone as our LPA, we haven't handed that power, that voice over to somebody. So really, really important document, just as important as doing a will. It's currently, I think it's £84 per application. So if you were doing health and welfare, £84. If you're doing property and finance, you'd pay £84. If you've got a run-of-the-mill life where no complications, you can actually do this yourself. I've done my own, myself and my husband did ours. Really easy. We filled them in, we had some witness signatures, sent it off to the OPG to be ratified, and then that's it. I took a few photos of it on my phone to be able to, if something happens, I can then say, hey, here's the LPA. You can look at the detail of it and see that it is a genuine document. So people don't have to go to a solicitor and pay thousands and thousands of pounds to have this done. This is something you can do yourself by printing this off the website and getting it in. And like I say, if anyone who 18 and over should have an LPA for health and welfare. If you want to have given your voice to somebody around those decisions when you lack capacity, this is the only legal document that is going to do that. Yeah, your next of kin's example, that they are not going to get you there. So I'm going to come on to talk a little bit about advanced decisions to refuse treatment. And this, I think, is a slightly trickier part of the Mental Capacity Act than LPAs, because advanced decisions to refuse treatment, so this is not a do not attempt CPR form, nor is it a respect form or any of those. People can have all of them as well as an ADRT. So when you have an advanced decision to refuse treatment, you've got to be over 18 years of age. And when you have capacity, you are writing down what particular treatment you are going to refuse in the future when you lack capacity. So it's a refusal of treatment. You cannot demand a treatment on an ADRT. And you need to be really, really clear about what that refusal of treatment is. So we often see people who have multiple sclerosis, motor neurons disease, long-term cancers. They know where their health journey is going, and we know we've got those wonderful charities around that will help and support somebody to write an ADRT. If you come across an ADRT, the difficulty with them is there is no lovely LPA form like we had on the previous slide. You can record your advanced decision to refuse treatment on whatever piece of paper, scrap paper, notebook, post-it note, whatever you like. And as long as your signature has been witnessed and signed, you're not witnessing the decision, your witness is signing to say they witnessed, say you've got capacity on that day that you made it, that is a legal document. Okay, so if you look down to your notebooks today that are probably around you, you could get off, one piece of paper, write your decision today, ask your colleague to sign it. That would be a legal document that would be legally binding in that situation. What's absolutely key is if somebody comes up and says they have an advanced decision to refuse treatment, you must see it. Okay, so if that person, their family member or whoever, they can't find it, we carry on with that treatment until we can see the detail. Okay, we absolutely must see it. Okay. So like I say, most people have been supported to write ADRTs, and they're very well written. I worked with a chap who had motor neurons disease, and he said having a tracheotomy to him was too far, that was too much, and he just wouldn't want that. So he then wrote an ADRT to say, in the future, if I lack capacity and it's at the point that I need that tracheotomy, I don't want it. And that's actually what happened. And that decision was respected. It's like I say, it's a legal document. We then work within that, and we were all clear on that was his decision. Right. So coming on to talk about deprivation of liberty safeguards. So probably lots of you on the call are more than used to DOLS and why we have DOLS. But if I just give a bit of context around why we have DOLS. So deprivation of liberty safeguards came in 2009, and it came in on the back of the Mental Capacity Act. And that's because we were assessing people's capacity in care homes and hospitals, because that's where we use DOLS, to say, could the person consent to living in that placement? And the outcome of the assessment was no, they couldn't. So then we were saying, well, the person's now not free to leave. But actually, the big hole in the net, if you like, was that we had no legal framework to actually stop that person from leaving. So we were trying to say at the time, well, it's in their best interest to stay. Well, you can't hold somebody somewhere under their best interest long term. That goes against your human rights, doesn't it? So we had an amazing case. It's called the Bournemouth judgment, and it's Harry and his family. Again, the YouTube link's there, but I will share it in the pack. Him and his Harry's just him and his family are just amazing. So Harry was adopted by his family, and he was going to daycare. He had a learning disability, and on one day on the way to the day centre, he sadly had just a really bad experience. There was traffic. He found the journey really distressing. So by the time he got to the day centre, he was not in a good place, and at the time, the decision that was made was that he would just be put in the severe behaviour unit. So that was it. Harry was then locked up in the severe behaviour unit, parents not allowed to see him. He wasn't allowed to interact in his community, in his world that he had been, all because of this one bad journey. So Harry's family took it upon themselves to challenge this to the courts, and they went all the way up to the European Court of Human Rights to say this is absolutely not okay. You know, there is why are you stopping our son from leaving? Why are you stopping us from visiting him? And the courts ruled in their favour and said to the government, you need to bring in a legal framework that supports and wraps a safe hand around our most vulnerable people in our care homes and hospitals. So the government then brought in doles. Doles isn't perfect. Sadly, there are, you know, again, I think it was probably bought in a bit too quickly, and there are still some holes in the net that remain. But we have heard in the last 2 weeks that the government are going to start looking at the Mental Capacity Act Code of Practice and the Doles framework, and looking at bringing in a new system that will be called Liberty Protection Safeguards. And from what I've seen on some of the draft papers that have been said about that, it's looking good, it's looking positive, but how long that will take, I don't know. So for now we have doles, and this is the framework we use. So what happens, so for a person to be able to be put on the doles framework, you of course have to assess their capacity. And so remember, it's for care homes and hospitals only. If you're from a hospital environment, you can only put people on the doles once they're clerked into a ward. Doles cannot be used in the emergency department or intensive care units, okay? They have to be clerked into a ward, and the person has to be able to take part in the assessment, so that mental capacity assessment. Obviously, we know that if that person can't have that conversation with us, then we've not used our 5 principles of the Mental Capacity Act, have we? So we assess their capacity. The outcome is that they cannot consent to living in the care home or being on that ward. We then need to put the doles around them. So the doles consists of 6 assessments, and they are completed by a Section 12 doctor and a best interest assessor. And what happens is that person will be spoken to. Their views and wishes will be asked about how they feel about living in a care home. You know, how do they feel about them being locked doors, or maybe cameras in the corridors? You know, how do they feel about having bed rails or low-level beds with crash mats? And we have a very person-centered assessment with them. From that, those 6 assessments that we complete, the decision is then made if the person meets the legal framework to go on a doles. Because what you've got to remember is when somebody goes onto that doles legal framework, they essentially lose their Article 5 rights. So your right to liberty and security. Yeah, so really, really key. So it's a big loss of a liberty to be able to say to somebody, you're not free to leave that building, you're not free to walk out of that door. Yeah, we need to be really clear that the criteria is met for that person to go onto a doles. And then that doles is in place for 1 year, and then that doles has to be reviewed after that 1 year to say, is everything as it should be? Is everything, are those safety netting arrangements, that advocacy role still around that person? And then the doles can be revalued for another year. So just to be mindful, doles is for people who are 18 years and over. So we have our first problem there, because we know mental capacity is 16. So we then say, well, what happens to our 16, 17-year-olds that we're assessing capacity for? If you've got a patient of that age, you need to be going to the Court of Protection, because the Court of Protection will need to authorise that doles, okay? That cannot go down the normal legal framework with your Section 12 doctor and your best interest assessor, okay? Just a couple of points about doles. One, if there's any conditions on the doles, they are conditions and they have to be met. Generally, the conditions that I see when I go out and review people's doles is normally around covert medication, because again, covert medication is seen as a really big intrusion on someone's life. If someone's having antipsychotic medication or dementia medication or Parkinson's medication, and they don't know that they're having it mixed in yogurts or jams or whatever, that's a real heavy restriction. And often what I say is if that's a case of covert meds, that medication covert plan needs to be reviewed every single month to make sure it's still appropriate and necessary. So again, we don't just fall into that, oh, well, we do it that way because, we make sure we keep revisiting it, fresh eyes on, is this still necessary? The other thing about your doles is that at the moment, sadly, it's not portable. So it's a bit hit and miss. So if you've got someone who's constantly moving between hospital and home, a care home, their dolls is going to keep falling away, and they're going to have to keep having that re-referred for every time. And that's one of the big changes under liberty protection safeguards. Just be mindful, you might come across, for those of you who are working in the community, if you come across anyone who has restrictions on them in their own home, that's called a community doll. So you drop the S. And if you are recognising anybody that, you know, like say cameras or people who have 24-hour living care, constantly have someone with eyes on them, they know where they are, they have no freedoms, or they don't know the key code to their door lock, you need to highlight them to the social care team, that they need to go on to what's called a community doll, okay, or be assessed for that. And again, because they get all those protections by having a community doll in place. So dolls for people in care homes and hospitals, and community doll for those out living, you know, as everyday. Right, any questions?
No, there aren't any questions at the moment.
Amazing.
I
Okay.
know. You're being
So-
very thorough, Lisa.
Thank you. So just to be
Sorry,
really...
there is a question.
Oh,
Sorry. It
fabulous.
says,
Go
is
for it.
that applicable to supported living? The community doll, I'm assuming.
Yeah, so again, I would just, so somebody in supported living, they probably fall under your deprivation of liberty safeguards, because that supported living placement, if it's registered with the CQC, then it comes under DOLS, because the local authority have got a responsibility to know that that's a registered care home. Yeah, so it's somebody, if they're living in their own home, you know, they've got carers coming in, you know, family have arranged for them to live there, that's your community doll. Yeah, anything that's got sort of, if you think about it, just clear cut, anything with the CQC registration, then that's deprivation of liberty safeguards, that's your dolls.
Okay,
Brilliant.
so somebody is saying that supported living is community doll, and it's not under dolls.
Okay, well, I'm happy to come back, and it's to do with the CQC registration, because that's where that you know, it's impunitive to the state, it's that part of it, so I can go back and have a look. Just to say as well, for people on dolls, it's not, you don't have a dolls for one home, okay? Your dolls is purely about individual people. I've heard people say to me, oh yeah, our whole home, everybody's under a dolls under one. That's not true, okay? That's again a bit of a funny myth. Again, because it has to be person-centered, that person has to have had those assessments completed. Oh, got a microphone on somewhere.
Microphone on.
I'll just pause for a minute, otherwise I get feedback, it really throws me off. Yeah, so dolls is purely about that one person, it's not about a whole home cannot have a dolls for everybody. And a dolls is purely about saying the person isn't free to leave. It's not about any other procedure or treatment. So if you want to be doing any other procedure or treatment to that person, you need to go back and do a Mental Capacity Act assessment. Yeah, so again, just again, I've got, you know, had some horror stories where people have had treatments done to them, and when we've questioned why, they said, well, they're under a dolls, and I said, that's nothing to do with them having that treatment. You should have gone back and assessed their capacity and made a best interest decision. Yeah, again, I hear lots of people saying, oh well, you know, we're doing that restrictive practice because, and I said, well, is it at conditions, is that they're on their conditions on their dolls, and it's not. So just be really mindful that we go back to MCA, we just purely think about dolls as the person's not free to leave. Okay,
so we've got a couple of dolls leads in the chat, so they're just confirming that dolls supported living is community dolls.
It's a community doll. There you go. Brilliant.
So we've got another question. It says, how long is an MCA valid for?
So it's time and decision specific. So I would say it's not about, none of them have like a time limit. It's about what is the decision and how often do we need to keep reassessing the capacity. So again, you know, if you're talking about, does somebody want to wear a jumper or a cardigan, that decision will probably last quite a long time, won't it? But if we're talking about the person continually, let's say, having blood, you know, having blood taken, we need to assess their capacity each time. Yeah, so it's about actually what is the decision. Yeah, not about length of time given to that decision. It's just not as simple as that, because it's decision and time specific. And that's where often I'll hear someone say, oh, well, we assessed their capacity a year ago and they lacked capacity. And our crews are on scene with the patient, and they clearly use their 5 principles of the MCA, and they've done their 2-stage test, and they've done best interest assessment. But the person, they do have capacity. We've done it all. We're really, really sure they do have capacity. So it's about that decision and time specific part of it.
Okay. So somebody says, is there a framework for determining how important the decision is, or is it just common sense based?
Yeah, it's just common sense based. Yeah, again, I always say, when you're assessing capacity for somebody, think about, am I the right person to be assessing capacity? Do I have the right knowledge and information to be doing that decision? So let's say, for me, if I was asked to assess someone's capacity around having, an amputation, I wouldn't assess their capacity about that, because I don't have that knowledge and information to understand how that's going to go, what that's going to look like, what are the repercussions, what are the treatment options, what are the pros and cons of that amputation. So it's about who is the right person to assess capacity. So in that situation, it would be the doctor or the anaesthetist to assess their capacity, because they've got the right information. If I'm being asked to assess someone's capacity around consent to hospital or consent to a referral or treatment, then I probably might be the right person. So it's more about having the right knowledge and information. Am I the right person?
Sorry. So we're having a conversation in the chat now about the community doll. And so somebody's come back and they've said it can be both. It's dependent on whether the person receives regulated care. Supported living is the type of accommodation. Dolls or doll apply whether the person receives regulated care from a registered provider.
Yeah.
So
all I would say is just make it known that that person has got that restriction on their life, and then let the right team know that they can then make that decision whether they're going to look at this as dolls or community doll. What's just really important is if we identify that that person has that level of restriction on their life, that we do something with that information.
And then we've got one more question. It says, what about the use of bed rails and the sensor motion?
Yep. So again, that to me would be a Mental Capacity Act assessment. So you should be completing a Mental Capacity Act assessment. Do they understand why they need bed rails? You would then get to the point where, let's say they don't, they lack capacity to understand they need bed rails. So your least restrictive and your best interest discussions would be, are you going to put bumpers around them? Is that going to maintain their safety? Actually, you'd go into the detail in that in your mental capacity assessment. Your best interest decision and your risk assessment would cover off we're not going to use bed rails. We're going to use a high-low bed, and we're going to have a bed sensor mat on the floor in case they roll out, and that's least restrictive. So again, it might well be noted on the DOLS forms why bed rails. I would note bed rails as a restriction on someone's life, but again, it still has to be proportionate and necessary. It is absolutely a restriction, but don't hold off doing that just whilst you wait for the DOLS. You would assess the capacity, have your outcome, make a best interest decision, and then risk assess it and have it in the care plan, so that's why you've got that in place.
Thank you. That's
Brilliant.
it for the moment.
Fab. So probably my last sort of parting comments before we finish up is, please be really, really mindful the difference between the Mental Health Act 1983 and the Mental Capacity Act 2005. And please be really clear under which one you're working. Am I assessing a decision around that capacity decision, or am I thinking the person is having a mental health disorder? And too often what I read in our service is this kind of getting a bit mixed up. And what sometimes happening is we're taking a little bit of the Mental Health Act and a bit of the Mental Capacity Act, and we're trying to put them together. And I would say just be really clear about what is it here that your patient needs. Are you talking about an assessment of capacity? or are we looking at those mental health powers that we need to go down? And just be really, really clear in your language. You know, don't mix these two up. They sound really similar, I know, but they are very, very different, and just hold on to that. So I think that might be me done. So I'm happy to move on to any other questions.
So I'm talking to myself. So we've got a question. It says, is a learning disability enough to justify an impairment, as this doesn't define a person's ability to make decisions? So can making...
Nothing, you don't see anything that it could
Can
be...
we just have everybody on mute, please?
Right, so...
It says, is a learning disability enough to justify an impairment, as this doesn't define a person's ability to make decisions, so can make determining... Oh, it moved. 51% difficult.
So the code of practice says, you know, if you've identified a learning disability, that can be classed as an impairment or disturbance in the functioning of the mind or brain. And again, what the law doesn't want you to do is start going off and digging deeper into exactly what that learning disability is. Because you only need to be 51% sure. So you are naming it, you are saying that's the reason why.
Okay. We've got a question. It's, do we always need to do MCAs in doubles? So do we need a witness?
Again, I would say it would come down to the decision that you're trying to make. So on what scale is this decision that you're making? Is it a low level decision or a high level decision? And again, actually, if you are going out in pairs and you're making that assessment together, then to me that's that's part of that best interest conversation that you're going to be having. But again, if you're going out in a pair from the same agency, the same team, I would say actually there's probably not enough wider consultation there. You probably would want to go a bit further and have wider consultation with other agencies, other people that know that patient well, so that you're getting a nice holistic picture of that person's life.
Okay. Is there guidance on how many capacity assessments are documented? We could go on forever. Is it enough to have an overarching support plan explaining daily minor decisions?
Yeah, and that's what I said, those smaller decisions can stay. You know, when your resident first moves into your care home, or, you know, the first person you start working with them, yeah, you would probably do, you know, your basics around food and fluid and nutrition and personal care, those capacity decisions, and you'd have those care plans in place. And then absolutely they can stay there, because they are those lower level decisions we're not going to worry about. You know, they're not going to be, you know, intrusives on their life. But we're going to be then updating that within the care plan, and we'll be looking at those care plans and saying we've reviewed them monthly, we've reviewed them 6 monthly. It is still valid and applicable into how best to support that person in their life.
Thank you. We are having further conversation about community dole and doles in supported living. I've asked Suzanne to send me through some information. She's put quite a lot of information in there for people to read. We've got another question. We have a client in our hostel who had an MCA assessment from the mental health team, and they deemed said person to lack capacity. The client has no contact with anyone, and we managed to get them an advocate. However, now the advocate is saying she doesn't have the client's consent and will need to close the case until the client either gives consent or is allocated a social worker. Where do we stand? What can we do for them while we wait?
Yeah,
they're currently on the waiting list.
Yeah, that's a really challenging situation, because you kind of got yourself stuck between the rock and the hard place there. I would say, if possible, if you have the availability to go and from your organisation seek some legal advice around that, that would be my suggestion, because what you don't want to do is not support that person in the way they need to be, because you're caught up in a GDPR sort of in Data Protection Act part of the world. So yeah, I'd go and seek some legal action, legal advice if that's possible.
Okay. If anybody else has any more questions? if you can put it in the chat, please. You're welcome, Tony. Tony just said thank you. While we're waiting to see if we've got any more questions, can I put one of my polls out, please? And this is just asking people from today's session, what do you think that you will take away? Let me find it, please. And I shall just put it out. So what one action will you take as a result out of the webinar? It should be on your screens now. I've got somebody who's asking for contact details. Have you got contact details as part of your presentation, Lisa? And are you happy for people to contact you?
Yeah, absolutely. And I did drop my email into the chat at the beginning of the session. I'm happy to drop it in at the end as well.
Okay. So we have a question that says, do we need an ADRT and a DNR, or is the ADRT enough?
So it's the patient's choice. So it depends how detailed they want to be with their ADRT, but they need to make sure that they have covered off all those treatments that they would want to refuse. So again, you know, I see people who have respect forms, do not attempt CPR and ADRTs, and they've kind of got a full host of them. So it really is patient choice.
Are you able to see the responses?
I can, yeah, they're popping up and moving about, yeah.
Okay, yeah. Okay, I'll put my contact details in there as well, Suzanne. Thank you. So as you can see, lots of people that, you know, just general MCA information, but MCA policy, ADRT, I think that was the one for me, actually, the ADRT, the OPG information, just better understanding of MCA. So there are lots of things that people will take away from that. I think for me, there was the LPA stuff about having that when you're younger. You know, I've just done mine for my dad, who is in his 80s, that we actually didn't pay for because of the benefits that he's on.
Yeah, brilliant.
So we didn't have to pay for it, and we did it ourselves, which I know has saved a huge amount of money as well. So I would recommend that.
Yeah, I've had some real horror stories of people sort of paying £5,000-6,000 for an LPA. And if actually it's been a very simple LPA, you know, that the person could have done it themselves, but that, you know, sadly they have been very overcharged. And I don't think people realise you can do it yourself. You don't have to have a solicitor. Yeah.
And if you get it wrong, they'll send it back and you just redo the bits that are wrong. There's no hassle with it really at all.
Absolutely. Yeah, and really important that you do it before the person lacks capacity, and as soon as you do it, make sure you send it off to be registered, because if I only found out a few weeks ago when I was checking with my in-laws that they had theirs. They said, yeah, they were in the drawer ready to be sent off, and I said, what do you mean ready to send off? And they said, yeah, we haven't sent them off yet, we're waiting. I said, waiting for what? You know, get them in the post.
Exactly.
Yeah, so it's asking those, you kind of go, have you got LPA? And they say, yes, you have. And then it said, have you sent it to the OPG and got it set? Yeah, all done. They were like, no. So that was my learning.
Yeah, definitely. And then the final poll that I'm going to put up is just a repeat of the first one, which was about your confidence levels. So in relation to MCA, how confident are you in this subject now? Thank you very much. Oh, good.
Hi, maybe I can give a quick feedback, if that's okay. My name is Maggie. I'm from Parkside Care Home in Reading. I personally feel quite confident, and it was, I think, a lovely refresher, lovely top up, some new information. It was very, very useful. I liked it. But if you ladies don't mind, I always ask, not always ask this question, but I have this question. With the residents who are being transferred, initially referred to the care homes from hospital, do we always have evidence of mental capacity assessment being completed in the hospital prior to person discharge to the care home? Because we had few instances where we admitted residents who had capacity and they didn't have family members who would advocate for them, who would have lasting power of attorney. And we admitted residents who were telling us, well, can you please help us to find out what is going on? We didn't want to come to the care home. We feel like it was decided. So where do we stand with the mental capacity assessment regarding discharge from hospital?
Yeah, I mean, I would say best practice would be that the person has their capacity assessed in the hospital to understand, their discharge destination. Whether that's always done is probably questionable. Marcia, I don't know if you'd agree with me here, knowing the pressures that are on those very acute services. But yeah, again, what I would be doing is when that patient is arriving with you, is I would be completing my own mental capacity assessments, refreshing them, looking at them from my eyes, remembering that it's decision and time specific, getting a bit of time to know that patient. Again, I would be maybe a little bit concerned about who completed those mental capacity assessments in the hospital. How well did they know the patient? Was assessing someone in hospital the right environment? Well, that's, if we think about the support principle of principle 2, actually, to me, it'd be best practice that you then reassessed and redid your own mental capacity assessments when that resident is settled in the home with you.
Thank you.
You're welcome.
Lisa, anything else from you?
No, just all I say is don't be scared of the Mental Capacity Act. I know that lots of people feel very scared about using the MCA, but I think if you actually break it down into making sure you use your 5 principles, that the way I showed with the hand, and thinking about your 2-stage test and your best interest decision making, you don't need to be scared of the Mental Capacity Act. Come back to thinking, am I the right person to be assessing this decision? And if you feel unsure, you're not sure, go and speak to somebody. Don't just leave yourself in that vulnerable position. Share. Ask questions.
Thank you, Lisa. Thank you for your knowledge and sharing your knowledge with us. I hope that you've all taken something away from this afternoon's session. I just wanted to remind you all that there are further sessions available during Safeguarding Adults Week for the rest of the week. So please have a look on the website or on any of the communications that you're receiving about Safeguarding Adults Week, and see if there's anything else that takes your fancy. There are some really interesting sessions, really interesting speakers. So I hope that if you haven't already joined up, please have a look and see if there's anything that takes your fancy. That's all I'm saying. Thank you very much for joining us.
Thank you, everybody.
Okay then, bye-bye.
Bye,
Thank you,
everyone.
bye-bye.